Good evening, sir.
Good evening.
The service session okay?
ഒന്നുമില്ല, എങ്ങനെ പോകുന്നു?
ഞാൻ കഴിഞ്ഞ ആഴ്ച ഇവിടെ സ്ഥലത്തുണ്ടായിരുന്നു. ഞാൻ ഖത്തർ കപ്പിന് പോയത്, വേൾഡ് കപ്പ്.
ഓക്കെ ഓക്കെ ഓക്കെ. ഓ ശരി. Good evening, man, sir. Last week I did a good case. Today good. Yeah, tell me.
Sir, you can start. I open the room. You can start whenever you want.
Yeah, just 2 minutes. Just 2 minutes. Wait for 2 minutes and we'll start. Good evening. Babu, definitely I will, next week I will present this IAN, present my IAN presentation. So I somehow or other forgot to bring this time. Next week I will show that.
Thank you, sir.
Yeah,
Thank
that
you, sir.
tricks of the trade, no? Yeah,
Yes, sir.
Yeah, I will, in fact, I forgot about it. Next
Sir.
week I will show that, definitely.
Thank you, sir.
Thank you.
Thank you, sir.
Bindu, good evening, Bindu. Shall we start? Okay. Is my screen visible to you?
Yes, sir.
Yeah, so we'll start with the, today I will start with the ultra short case first, only for 2 minutes case. Then I'll go for a really challenging case. This is a story of a 60-year-old man. He gave history of difficulty in eating food for the last 4 years. No other complaint. In fact, he has no difficulty in swallowing, but problem mainly in chewing food. No difficulty in drinking water. This is the video, no other complaint. This is the video.
ഇവിടെ നോക്കിക്ക് ഇവിടെ മുകളിൽ താഴെ പല്ലിയാണ് ഈ
Case policy. Movements are apparently normal.
ആന്ന് പറ നാക്ക് നീട്ടിക്ക് ഇരിക്കുന്ന അസു മനസ്സിലായി ഞാൻ പറഞ്ഞു തരാം കേട്ടോ.
So what do you want me to do? Rest of the silence examination all normal.
Video is not coming properly, sir.
So your video is not coming? Okay, I
ഇവിടെ
will say
നോക്കിക്ക്
stop and share once again. Just 1 minute.
No, we could see the video, sir.
Okay, I will share
You could see, sir. You could see the video.
Okay, I will share once again, no problem.
മുകളിൽ
Is the video seen now?
Yes, sir.
ഇവിടെ നോക്കിക്ക്
Yes, sir. I can. Hello.
Yeah.
Hello.
Hello?
Yes, sir, we can see you. You can start.
Okay, I'm starting already. His complaint is mainly difficulty in chewing food, and examination did not reveal any abnormal finding. So in such case, what you do is ask the patient to chew food in front of you. So ask him to bring 2 bananas and then come to my ward to eat in front of me, and this is what he I'm asking him to speak. I ask him to put banana is no. This is the problem with him.
Task force dystonia.
Yeah, well, that's a simple case. So in fact, it's a segmental dystonia precipitated by eating. The jaw gets opened and the neck goes into flexion, and the tongue also makes the food make it protrudes out, so that you cannot the food particle cannot go backward. The tongue pushes it outward. This got to affect dystonia affecting the jaw, tongue as well as the neck. Okay, that's all. Just yes, other investigations were all normal. This is one kind of a focal dystonia occurring in an adult. Such a case in a younger age group with other findings, you should rule out the condition like choreoacanthosetosis, then Huntington disease, drug-induced dystonia. Drug-induced usually will disappear while eating. That will present otherwise. And PAN2 in younger age group. These things should be kept in mind. Okay, so I'll go to the proper case. This is a long case with a lot of videos, a lot of pictures also. This 44-year-old man came with the history that 1 year back, his complaint started as mild burning pain of right lower limb below knee, followed 2 months later by similar burning sensation of the left leg. About 4 months later, he noticed heaviness of the right lower limb in the form that he has to put extra effort to push his right leg forward. After about 2 months, he noticed similar feeling in the left lower limb as well. No complaints pertain to the upper limbs or tendons. This is only the story. Mild burning pain, not a severe pain, the right lower limb below knee. Similar burning pain in the left leg as well. They notice some heaviness of the right lower limb, followed by heaviness of the left lower limb. But still you could walk about, get up a squatting position, no complaints pertaining to the upper limb, no other complaints. No bladder problems. So this is the video of the patient. His tail live examinations were all normal. This is a very interesting. Facial movements are all normal. He had no wasting in the upper limbs. Suspicious wasting, not definite. Tone was normal. Grip was normal. Deltoid normal. Biceps normal. Biceps normal. Wrist extension normal. Finger extension is normal. Small muscles are all normal. No finger nose incoordination. No achanesia of the upper limb. So you could get up from lying position without any problem. There is no behavioral sign. And come to the lower limb, tone was normal in the lower limb, not spastic. Hip flexion was mildly weak. he could overcome with two hands on putting pressure by two hands. This way of examining also hip flexion was weak. But I have to put real good effort to break the hip flexion. It's weak. About 4 plus. The extension was normal. That's also normal. Hip abduction normal. Adduction normal. Hip extensions appeared mildly weak. They appeared mildly weak. Wrist flexion was normal power. EHL was normal. Plantar flexion normal. That also is almost normal. I think the abduction, lying down position, I could overcome it, but it's mild weakness at hip abduction. The other side also I could overcome. Examine the gluteus maximus, that was weak. The flexed knee position, he was not able to extend the hip fully. I could overcome that. So hip extension was weak. The flexes upper limbs, biceps, normal. Supinator is also normal. But there's some suggestion of a inverted supinator on the right side. Their fingers go into flexion. Supinator could be elicited, but finger flexion was out of proportion with this. It is not there on the left side, more on the right side. Triceps was diminished. It is there, but just elicited. The flicker of movement is only. Right side also is a flicker of movement. Finger flexion was brisk on the right side. Left side was normal. Abdominal reflex were absent. Ajax brisk bilaterally. Slightly more on the left side, but bilaterally brisk. Anglejax was normally elicited, not brisk. Plantar right was upgoing. That is upgoing. Left was maybe upgoing, not very convincing. We call it indefinite. Sensations were all normal, except might decrease in the temperature below the knee. Touch is normal.
ഞാൻ ഇങ്ങനെ കുത്തുമ്പോഴേ ഈ കുത്തുന്ന മേന അറിയാമല്ലോ, ഇങ്ങനെ കുത്തി മുകളിലോട്ട് വരും. മുകളിലോട്ട് വരുമ്പം ഇതെല്ലാം ഒരേപോലെയാണോ വ്യത്യാസമുണ്ടോ എന്ന് പറയണം.
Is it same all throughout? No sensory level anywhere on it.
ഇതൊക്കെ ഒരേപോലെയാണോ തോന്നുന്നുണ്ടോ?
Vibration normal in the upper limb as well as the lower.
ഇപ്പോഴേ ഉണ്ടല്ലോ, ഇപ്പൊ ഉണ്ടല്ലോ. ഈ വെച്ചതും
The temperature is less also. It's mildly decreased on the next below
ഈ വെച്ചതും
knee.
ഇതും
ചെറിയൊരു വ്യത്യാസം കുറവുണ്ടോ?
Joint sense is normal in the upper limb as well as lower.
അതേമാതിരി കാര്യം പറയണേ. ലൂസാക്കിയിട്. ഇപ്പോഴെങ്ങനെയാ?
Okay, normal. So the second part of the video, it is quite okay. Not much of abnormality you can make out. There is no spasticity. You could thrombus is very possible, not possible, mildly possible. Not very convincing. You could walk on tandem, no total power, except for mild incoordination. You could stand on heel. You could stand on toes. Pendulum appeared to be positive on one side, not on the other side. When he stands on the right, left, the left hip sags. Is that striking mildly parallel? Sagging is on the left side, indicating mild abdominal weakness on the right side. When sitting with one foot lifted up, he could get up from the opposite leg. That means got a good cortices power. Then tried to make him sit up with the right leg. Again, he could do that. So these are the some findings. So tailless normal, motor system, upper limb tone power normal, lower limb weakness hip flexes, hip extensions, hip abductors bilaterally. About all are grade 4 plus power. Rest of the muscles grade 5, no incontinence in the limbs. DTR upper limb bicep supinated normal, or inverted supine repressed from the right side. Triceps decreased bilaterally. Finger pressure brisk right side, normal on the left side. Knee jerk brisk bilaterally, angles normal, under both outgoing. Left, of course, you can take plus minus. Abdominal plus absent bilaterally. Sense system all normal, except for mild decrease in the temporal sensation over both legs. Rombeck's negative, gait normal, tandem walking normal. He can walk on heels and toes, and he can get up a stair with one foot lifted up. So this is your finding. Any clarification you want in the finding or video? You want to show the video once again? Some point you can ask.
Sir, any posterior impairment in the sacral region, proximal?
Sacral area I did not look. Posterior test sensation.
I mean,
specifically, I did not look at the sacral area. Or the feet, everything is normal. But it should be suspected period. There's no complaints there also.
And I mean the iliac crest and the lower spine.
Yeah, they're all normal. That's correct. That's not.
The C567
radiculopathy
examination slide, sir.
Yeah, it's got a radiculopathy probably with a myelopathy below that, correct?
and also probably L1 with S1 radiculopathy also because the proximal weakness in the lower limbs without the EHL and others involved.
Yeah, correct. That's perfectly right. But only thing is the knee jerks also brisk bilaterally. The lower limb reflexes were also elicitable. But we cannot definitely say LMN, probable LMN, right? Because that's not fitting with the pyramidal weakness. But the only weakness is so mild, it's not very gross weakness. Okay, that's a good thought. So,
sir, this looks like a lesion. The C67 radiculopathy with the myelopathy,
correct,
and the predominance is a proximal weakness compared to the distal. So probably, and the onset was asymmetric. So probably a compressive lesion more maybe in the medial part of the cord, growing laterally.
Yeah, right. So that's a possibility. But remember, the weakness is subtle, not very gross. You could get up from sitting position, squatting position, you can stand on one, we can see that. So those things, mild, I can, with great effort only, I can block and break that weakness. Okay, anyway, still there is mild weakness, I agree with you.
Because there is a disparity between the distal and proximal. That's
correct. That's correct. Right.
So regarding the sensory, sir, started as a burning sensation in the legs.
That's what he said. Correct.
So that cannot be explained by this radiculopathy postulation below knee.
Yeah, correct. You have what you said is correct. You have to think of a tract lesion, correct?
Yes, sir.
Yeah, right. So the radiculopathy, you are not very certain. Because reflexes are also well on the viscous side.
If you are thinking about the lower leg tracts, it would be more laterally placed.
Correct. Right. So what do you think the site of lesion is? Cervical cord, no? Whether extramedullary.
That would be bilateral, lateral aspect of the cord, sir.
Yeah, correct. Extramedullary compression, agreed. Only thing is, as Umar was telling, proximal slightly more weak, that's slightly odd, but still overall picture is more like an extra because reflexes are absent at that level. Below there is a pyramidal lesion. Agreed.
Like a dissociative sensory loss in the lower limbs, with the just the.
Yeah, that sometimes, yeah, dissociated sensory loss is there, but that's due to the segmental involvement there because the reflexes are all well elicited. So if it is a dissociated sensory loss due to intramedullary lesion at that level, reflex should have been absent. So it's it's a tract involvement itself. Okay. So in fact, this finding is what I have shown you is the present finding, which I'm seeing now about 3 weeks back. In fact, I had seen him 5 months back with exactly the almost similar finding. And that time I did not get in postural muscle weakness because probably I did not examine that in that detail at that time. It was no OPD. Probably it must have been there at that time itself. This was the note at that time. This is written when I saw that. Here I written Corey spasticity, then abdomen reflex absent, rest of the things fine, it's all the same, no sensory, etc. So he was suspected as cervical myelopathy, peri-compressive, peri-non-compressive, more like a compressive body diminished triceps reflex. In fact, he came with MRI of the brain and cervical spine at that time, when I saw him 5 months back. The brain showed a pituitary mass lesion. So this is a cervical spine, essentially normal, mild disc bulge. This is axial cut, no much compression at all. This MRI brain done at that time showed a pituitary mass. This is the flare sequence. Uppercut, no hemispherical lesion. T2 shows a pituitary mass here, occupying in the cella and the supracellular, going to the supracellular region. There is no hemispherical lesion in T2 to account for the weakness here. So this is the cellular mass. It is going above the cella, compressing the chiasm. Okay, it will compress. But he has no visual complaint, no headache, no complaint pertaining to the pituitary lesion. It is going above the cella, just abutting the chiasm. This is the T1 weighted sequence. Now, this is done earlier. So now what will you do now with that thing?
Repeat neuroimaging with contrast, cervical spine, cervical and dorsal spine.
Okay, cervical and dorsal spine. This was done 5 months back. The similar finding at that time. Anyway, I'll tell you the story. So because there's nothing in the compression, the homocysteine level, which is also normal. So in fact, I was planned for admission for a DT evaluation of his so-called non-compressive myelopathy. He got admitted in another major hospital and investigated for the last 5 months. There he was put on treatment for the next 5 months. I'll tell you what treatment he received later on. But he did not get any relief. That's why he came back again. So now I'll show in the order what are the investigations done in the previous hospital. They done extensively worked up the case. So first they investigate for the pituitary mass. They did the thyroid function test, TSH normal, FSH, LH, prolactin normal, cortisol level normal. ECTH was normal, human growth hormone normal. And they did a field charting. Again, there was no field deficit due to the optic asthma compression. So it's something is. No, they did an ultrasound scan of the abdomen. I do not know why they had done it. That showed significant post-viral urine residue about 350 cc. Whether it's an unrelated problem or not, why they have done, I still do not know. Anyway, MRI cervical spine. Yeah, please.
Sir, was there any urinary complaints like poor stream or anything?
No, he had absolutely no bladder problem. No urinary complaints at all. Then the MRI cervical spine, lumbar spine was repeated in that hospital. That picture is not available with me because that was in a CD which I could not open it. I'll tell you the result, what they have written. MRI LS spine done on 22nd June 2022, there is evidence of clumping of podaceous nerve roots with thickened and hyperintense lumbar plexus nerves. Similar thickened hyperintense nerve roots noted in the bilateral brachial plexus on screening of the brachial plexus. Post-contrast can show mild contrast enhancement of the caudate nerve roots and lumbar plexus. This is their MRI report. So their final impression, in the case of low back ache with bilateral lower limb pain and paresthesia, MRI shows clumping of the caudate nerve roots showing mild enhancement with thickened and hyperintense lumbar and brachial plexus nerves with mild enhancement of the lumbar plexus. Chronic inflammatory demyelinating polyneuropathy. This is their impression. That is why they put the patient on treatment. Now, the other investigations done at that time, the hemoglobin, total count, everything is all normal. Thyroid TSH normal. Rheumatoid factor CRP was normal. Blood sugar was high because they have put on steroid at that time. The other investigations, ESR was normal. Serum potassium, creatinine, cholesterol, triglycerides, bilirubin, LFT, serum proteins, CPK, calcium, hemoglobin, APTT, are all normal except ANA was mild weakly positive. That can be, I think, taken as normal. Then they did HbCG and HAB. Then peripheral smear was normal. Urea, nitrogen, sodium, glucose, cholesterol, SCOT, alkaline phosphatase, everything was normal. They did anti-DS DNA was also normal. TSH was normal. APL, pardon?
ACE.
This is the
ACE level, sir.
No. I'll show. I'll tell you all. This is not what I have done. This is the investigation and in the hospital. Just showing you the investigation results. No, this is not what I have done. Okay, whatever available, I will show the investigations. So AP, this is going to come. We'll wait. APLA was normal. Then ANGA, PANGA was normal. Antibodies were done. All negative. They did a CSF which showed 5 cells. And IgG index was normal. He had RBCs of 360, probably a traumatic time. And protein was 349. Culture negative, cytology negative malignant cells. They did EMG. They showed fairly symmetrical demyelinating motor polyneuropathy with conduction block, bracket, mildly reduced span. Okay. RNS, no significant electrodecremental. I have not seen this values or anything. This is only the discharge summary note I am putting. There he was put on injection solumental for 5 days, followed by weekly injections IV, 1 gram solumental for next 6 weeks, and then followed by satellite. They also did serum protein electrophoresis, which showed gamma fraction. There is decreased with mild M spike seen and comment M spike seen in gamma fraction. Monoclonal. This is M spike, very small spike seen in the gamma fraction. They did serum immunofixation that showed IgG band positive, lambda band positive. Okay. Beta 2 microglobulin was mildly elevated. So they did that. They sent the patient, required the patient for hematology opinion. This is the referral letter. Here with referring this patient with the for serum protein electrophoresis showed decreased gamma fraction with M spike, and serum protein immunofixation showed positive IgG, lambda bands. Kindly examine your variable opinion. So they did a peripheral smear and bone marrow aspirate. This is the result of the bone marrow. Peripheral smear, mildly neutrophilic leukocytosis. Bone marrow aspirate, particulate cellular aspirate, and cellular imprint smear shows trilineage hematopoiesis with mild megakaryocytes proliferation. Refined biopsy result awaited. So they did a refined biopsy result. Impression bone marrow refined showing trilineage hematopoiesis with mild plasmacytosis.
3 months. 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 3 month
ANA profile was done November 22, again the same hospital on the follow-up normal. And this is the patient which had been on treatment. Now this patient has come back to you with complaint that there is no improvement. Now what will you do?
Doesn't look like CIDP because the breast reflexes and plantar upgoing and clumping of the nerve roots, which usually doesn't happen in CIDP.
Clumping can occur because when the nerves are thickened, sometimes they appear clumped together. But there should be contrast enhancement in that case.
So, arytenoiditis with the
reflex of breast and the plantar.
Yeah, reflexes are definitely in risk. You can see the breast reflexes. So what will you do now?
Sir, repeat nerve conduction study, sir, once.
Okay, so we are
neuroimaging contrast. Neuroimaging with contrast. Repeat neuroimaging with contrast and repeat NCS.
Okay, so the one thing is that, so I was surprised by the findings they have got. No, I never expected in this patient because I was suspecting a myelopathy and probable element, but not of this kind, no replacing. I never CADP diagnosis, I couldn't accept. So what I did is, so I admitted him as to come for admission. My plan was repeat NCS and EMG, repeat MRI whole spine with contrast. This is the patient I have done MRI brain, cervical spine, thoracic spine, and lumbar spine with contrast for 3 days, one bar after another, and did a repeat CSF. This is my plan. So let's see the investigation which I have done. This is the NCS. As meticulously as the electrophysiology into the NCS. Only abnormalities, mild decrease in the CMAP amplitude from the left peroneal. All other potentials were normal. Velocity was also normal. Latency was also normal. Right? All upper limb nerves were normal. Amplitude, velocity, latency were normal. Sensory all normal. And F5, there was left tibial was slightly prolonged. Other lower limb nerves are normal. In the upper limb, there is prolonged F5 latencies. So this is the finding which I got. Okay. So only abnormality electrophysiology is mild F5 prolongation in the upper limb. And one lower limb, there is a tibial, left tibial. Upper limbs are totally unaffected. This is a favorite. I went and checked the figure whether they are done correct or wrong. They done correctly, but only the number of, the persistence was not there in some nerves, but otherwise the FF latency is mildly prolonged. In the ulnar and all normal. This is median. So I did an EMG, which did not show any evidence of denervation in the muscles. In the corticeps, tibialis anterior, posterior dorsal, again, there is no evidence of any innovation or any fast firing rate of the potentials. So as I wanted to do the MRI again, once again, whether these findings are correct or wrong, because we have not seen the previous films. So this MRI whole spine, I'll show one by one. There is chord appeared normal, but normal CSF in intensity is not seen in the lumbar thick. Also the other films, better films. So I'll go one by one. This is the cervical T1. Normal. This is axial cut. Go away one by one. There is no hyperdensity in the chord or
very problem case. Peripheral sense out.
That's the thoracic cord. Then with the cervical contrast. This enhancement is not a true enhancement. There is no enhancement. The radiologist confirmed there is no enhancement on the cervical cord. Noted the MRI thoracic spine. In the thoracic spine, we found something else. He's got a fat deposition posterior to the dura. It's got epidural lipomatosis. Then do the thoracic axial to confirm. I'll show the deposition of the fat. This is the fat deposit posterior to that dura. This obliterating thoracic subarachnoid space. This is the fat. This is a T1, not T2. So this is the type of T1 film showing lipomatosis. The whole, usually thoracic, you find flavoids and CSF that is filled up with this fat. Now this is again showing the corresponding sagittal and the axial cut, showing the epidural lipomatosis. Here the anterior CSF posterior space is not seen, but cord is not much compressed. Only that CSF space is decreased. So contrast was done. This is a T2, not contrast. This is a T2. Again, you can find out that this small thing is a CSF. The one posterior to is the fat. I'll show the other feeling. The right one is the CSF, and the whole other thing is the fat. That is lipomatosis. This is the T2 sag. This is thoracic T2 axial. Again, you can find out that fat in the posterior aspect. Here, these are all the fat. This is the T2 showing the epidural lipomatosis. Contrast scan thoracic spine was normal. There's no abnormality, no contrast enhancement. Then MRI lumbar spine was done. This is the T2. Normally we should see a CSF there. It is not seen, either due to the clumping of the nerve roots or something occupying the CSF space. So this is the clumping of the roots. Or the normal CSF in between the roots are not seen. See, the clump roots or the CSF is filled with something else. That is an abnormality in the lumbar spine. This is the T1 axial. This is the T2. Normally in T2 axial, you should be seen clear space in between the roots. But that is not seen here. This is a T2 axial.
Is it because protein, CSF protein is very high, 600 hours.
The T2 axial.
Dark at the
So roots are not seen separately. This is a contrast film. There is no contrast enhancement of the lumbar roots. This is axial contrast. Not axial, not coronal contrast. Again, there is no enhancement of the podoaquinum. This is comparing T1 with this is the contrast. The other on the right side is the plain scan. It's no difference in the enhancement seen. The right side picture is little dark. That's all. This is the contrast and the non-contrast film in the lumbar spine. Then the MRI brachial plexus was done, which they thought was thickened. So we did a brachial plexus. The nerve roots is thickened more than normal in the brachial plexus. This is the flare. This is a still sequence. This again showing the brachial plexus. This appears slightly more thickened than normal. This is again at the state sequence of the right brachial plexus and the left brachial plexus. Then MRI the lumbosacral plexus. Really thickened, but not as much as the brachial plexus. That's a lumbar root. The sacral plexus is also slightly thickened. MRI brain showed that it's a T2. Same as before, he has got a cellular mass. This is the flare. This is the diffusion. This is the contrast brain. That's the enhancement of the mass lesion. This is the coronal cut contrast going above the cellular, brushing on the optic acid. And this is a sagittal cut contrast. This MR is sagittal, another cut, thin cut trailer. So this is a report I'll saying diffusely thickened nerve roots and dorsal ganglia of the brachial plexus noted C5 to D1 with still hypernear signals. The trunks of the brachial plexus also appear thickened bilaterally. No significant enhancement made out on contrast study. Then scanning of the lumbar spine shows similar diffuse thickening and still hypernear signals for bilateral lumbosacral plexus from L3 level downward. Bilateral femoral side thickness also shows thickening and signal changes. Maximum thickening noticed in the bilateral L5 nerves. No significant enhancement of the involved nerves could be made out in contrast study. Thoracic spine shows prominent posterior lateral epidural path in the thoracic spine from D2 to D9 levels with cord displaced anteriorly. Effacement of the thecal sac noted from D3 to D8 with collapsed ventral subarachnoid space. No cord signal changes. Then diffuse thickening and still hypernear signals the bilateral brachial summary. Past history of CVDP. Scanning of the thoracic spine shows prominent posterior lateral epidural path, suggestive of epidural hypermetrosis. They also found some avascular necrosis of the right hip, but examined the patient hip joint movement was quite normal. There was not pain manifestation. Cellular lesion features suggestive of pituitary microadenoma with predominantly intracellular extension with mild supracellular extension causing mass effect over the optic acid. So this is the findings. So I gave you, so what did you want? What else you want now?
Workup for sarcoidosis.
Okay, sarcoid.
Sir, is it possible that the pituitary mass itself is giving rise to this spinal epidural hypermetrosis?
No,
Something
that
like
cannot cause hypermetrosis. He is an obese individual. I forgot to mention that. He's very obese. You can see the picture of the patient. He's obese. That hypermetrosis usually occurs in obese individuals.
Something like a chemical meningitis causing a arachnoiditis like pattern. Is it possible like in this, like craniopharyngium and all?
Yeah, this is not, it's not craniopharyngium, it's like a macroadenoma, pituitary adenoma.
This macroadenoma causing Cushing's disease, not Cushing's syndrome. Is it possible?
No, the thing is that we have to explain the physical, the radiology, the has got a perimeter science you have to explain. why this investigation abnormalities like nerve thickening is there. Then I'll show some more things then before I discuss it. So
he probably has got a arachnoiditis due to some root in involvement and spinal cord involvement.
Right, that's a good possibility. But the thickening was seen even outside, no? The brachial plexus is thickened. Lumbar plexus is thickened.
But the CSF protein is high, sir. Indicating there is an inflammation of the roots.
Right. But I'll come to that. So I have some more investigation which I will show you. So first thing I did was I got a physician consultation to find out this gamma band and the M protein, how far it is significant. There is a mild M band, mild IgG index was normal. So senior physician saw it. He said that abnormalities in the immunoelectrophoresis in the bone marrow are within normal limits. So at least less than 10% plasma cells is normal. It's not abnormal. So this immunoelectrophoretic pattern is also only borderline, not suggestive of anything. So it's not telling it's not abnormal at all. So that part is taken out. So I did a repeat CSF. No cells in the CSF. But protein was more than 600. In fact, 600 and something. CSF glucose, no cells. Now these are the investigations. So I given you electrophysiology, CSF, and imaging findings. So how to go about in this case? Correlating clinically.
CSF is like an albumin-cytological dissociation.
So protein, lumbar CSF, no, you have done.
It's lumbar CSF.
So protein could be a distal obstruction also because there is a clump with this thing, no?
Right, correct. You're right.
The clumping, it can produce a distal obstruction and a pseudo increased protein.
Yeah, correct. There can be obstruction of the core, some in the subarachnoid space can produce elevated protein without any elevated CSF. Right, then. But how to explain? You have to correlate clinical and investigation findings. Stitch it up together to make a logical conclusion.
So he has got a spinal block, something like a Freund syndrome due to spinal cord lesion. And the root and the spinothalamic and the pyramidal can be explained with that.
Yeah, myelopathy due to something causing compression of the spinal cord, correct?
Yes, sir.
Inflammation or the protein is still causing compression.
And the nerve, I mean the root lesion maybe some roots also involved or infiltrated or involved with that same lesion.
Okay. But how to explain the thickening of the brachial plexus nerve roots?
That be normal also, the patient.
Right.
Normal thing, less like an epidural lipomatosis, diffuse thickening of the brachial plexus as well as the lumbar plexus is well known, sir. It has no significance as such, per se. If the patient does not have any symptoms, we have to omit this epidural lipomatosis in the cord as well as the brachial plexus as well as lumbar plexus thickening. Thickening per se has no meaning at all.
No.
Especially if there is no contrast enhancement, just we have to leave that alone.
Okay. But we cannot rule out the epidural lipomatosis, we cannot ignore.
Yeah, that can cause for the human signs.
Yeah, he has got a myelopathy and there is something causing compression there. Okay, so that part we cannot ignore. Other part I agree with you.
Sir, this is just like this histiocytosis, which has different just Chester variety, Dorspan variety.
But where is the lesion? Just we have say agree with you. Where is the lesion causing in that location to cause these?
The root clumping.
Root clumping. You mean to say that root clumping is responsible for the symptomatology of this patient? Yes, no, yes. But there is no element lesion in this patient.
Well, this patient has L2 S1 radiculopathy, which we think is LMN only, no? Because they cannot be pyramidal.
No, it can be pyramidal itself because the weakness is so subtle.
No, it's pyramidal. It's pyramidal low limb weakness will affect the distally
The only weakness what we got was hip flexor that can occur in pyramidal. If extension weakness is slightly odd, so that you can take as element, but that you cannot explain that element weakness. I mean, if at all it is present due to what? What is causing it? Is it
Proximal conduction blocks.
Yeah,
He has got a radiculopathy. His
right.
root are,
That's the point. I would make. So
हाँ तो वो तू सिटी ना बन सिटी पापा के मोबाइल खाली अरे वो स्कूटी
you know, somebody is speaking. Can you please mute your mic, please? Please.
वो तो ये देवेंद्र के डे चना लेकिन चाहे खबर ना इन्हन के खबर ना पाया ना कि हाँ तो खाली ना भाई यार साला खाली इनके
Asmita can.
So Asmita, can you mute that person who is speaking, please?
स्पीड पोस्ट करना बस
Yeah. Okay. Asmita, can you mute that particular person who is speaking? Asmita, are you there? I don't know who is speaking. Okay. So, no, you already taken, he has got a root involvement in the lumbar sacral roots because he has got a FA latency is prolonged. Okay. But that FA latency can explain some of the involvement of the proximal weakness. Agreed. That part is agreed. But you cannot explain the thickening of the brachial plexus and the lumbosacral plexus. Okay. Then we have to explain why there is a myelopathy. Is it due to epidural lipomatosis? But do you think that lipomatosis is sufficient to cause such an elevated, gross elevated protein? Sir, many things are tricky in this patient.
So the spinal block can give us.
Block, spinal roots are clumped and it is blocked. It is literally a block, no, sir, conduction block. No, so that itself can act as a myelopathy. No, they sometimes say.
What we see is for lumbar, the theca is filled with high protein ingredient. That protein can constrict the cord and produce some kind of myelopathy. That also agreed. But how often do you see that thing? Thickened nerve roots can compress the cord and can produce pyramidal cells. But elevated protein in the CSF itself, you can't explain it cause a compression of the cord. See, you say many patients who got elevated protein, but they themselves will not cause a compression.
Maybe contributory with the lipomatosis with this.
That can agree with you. Or either, as Umar said, maybe an arachnoiditis can produce that thing, can produce a constrictive arachnoiditis and elevated protein, Troyan syndrome, agreed. But there is no CSF cells is not there. There is no enhancement of the meninges there in the spinal cord.
Arachnoiditis usually produces pain also. The pain is also.
Yeah, and usually, if it was symptomatology, agreed. But even radiologically, usually the meninges will after enhancement will be there because arachnoiditis. So it's not fitting. It's not a simple case. It's a very, very tricky case. Let us analyze the problem one by one. The problem, yeah.
Is there any past history of surgery in the back or lumbar
puncture? No surgery, no past history of surgery, nothing.
If it's a TB arachnoiditis or a syphilitic, we recommend cells and contrast enhancement, and patients should have pain.
Correct.
The element and
right, exactly. There should be cells should be there. Pain, okay, you can call it mild pain is subjective. The other findings should be there. Contrast enhancement should be there. So it's not an arachnoiditis per se. Okay. Now the problem number one. Let's make me analyze. This is how I thought. Clinically, what does the patient have? So do you agree with the diagnosis of a CADP in this patient? I personally do not agree.
It is not CADP, sir.
It's undoubtedly a myelopathy. So what is causing it? The first question. Is there any compression, first of all?
Yeah.
There is thoracic lipomatosis with a near total obliteration of the CSF space. So that can easily explain the compression of the cord. Agreed. And elevated protein may be due to that. That is one way of thinking that he's got a pyramid. We have to see clinical correlation. Now, problem number 2, what is causing is thickening of the brachial plexus and lumbar plexus. Now, as Bindu was telling, was it incident? This, along with elevated CSF protein, could suggest CADP. But do you think it's CADP? There is no clinical or electrophysiological evidence to CADP. Because the upper limbs, nerves, brachial plexus are thickened. He had no weakness in the upper limb and electrophysiologically no abnormality in the upper limb. The only abnormality electrophysiological is mild prolongation of latency, and that too in the range not consistent with that of a criteria for CADP. Then one may argue that enlarged nerve roots may cause compression of the cord to produce pyramidal signs. But there is no evidence that the brachial plexus enlargement is pathological. Look at the upper limbs. No EDS abnormality in the upper limb, even though brachial plexus was more thickened than the lumbar plexus. And there is no weakness in the upper limb either. Even at all, mild weakness in the lower limb. Thickening was there in the upper limb, brachial plexus also, which is more than that in the lower limb. So this is most likely an unrelated finding, which we can't give importance to, because there is no clinical correlation for the thickening of the lumbar plexus. Now, problem number 3.
SSCP of the lower limb was done.
SSCP was not done. Because already if FAV is prolonged, then why should we go for SSP? Do you want to find sensory involvement also?
Whether the central sensory conduction, because the patient has burning sensation after both lower limbs.
That you can't make up record by SSCP. SSCP only assesses the posterior column. He has no sensory findings and there is no sensory potentials were normal. So, and you can argue that maybe lesion is proximal to that thing, but if you already that's a clue that the proximal there is a lesion in the proximal part.
Okay, sir.
Now, problem number 3, elevated CSF protein. The compression thoracic cord epidural lipomatosis is not severe. Personally, I thought theoretically you are right, it can cause elevated protein. But this much amount of compression, I don't know whether it can cause such a degree of elevation. Then the other thought is that could it be due to some protein secreting tumor elsewhere? As you all know that a tumor can somewhere, even CP angle tumor can produce highly elevated CSF protein can present. Similarly, spinal neurofibromatosis can produce papilledema due to its elevated secondary elevated protein. So then next question is, can pituitary tumor cause elevated CSF protein? Pituitary adenoma. So I searched the literature and found this thing. It can CSF protein in cellular region. It can be elevated as high as 500. These values which are quoted is some of the patients had up to 500 milligram of protein in pituitary macroadenoma. Now, in up to 500 milligram pituitary tumors, was this elevated protein responsible for the suspected clumping of the roots or the non-visualization of the normal CSF signaling of the lumbar theca? See, here we are not sure about the clumping. We are not seeing the normal CSF intensity in between the roots. That does not mean there's a clump. That only means that CSF is now occupied with something else, which is when taking away the bright signal of the CSF. It also appears the same thing. That can be due to the elevated protein itself. So we are not sure about the clumping. We are not sure about the nerve thickening because there is no enhancement of the roots. So probably that elevated CSF protein is causing the so-called clumped appearance of the lumbar theca because the CSF is not speaking. The CSF is not showing the normal signal. Now, could this elevated CSF protein responsible for the prolonged FAV latency in the lower normal conduction possible? As somebody was telling that that's a good thought. They also thought that possibility. But the FAV is normal in the upper limb. If that is so, why the FAV is not abnormal in the upper limb? But the CSF protein is more in the lower the lumbar theca that is causing it. Yes, that way you can argue about it. So these are the things which I would keep in mind. So what did you do now? He is on immunosuppressants and steroid.
Sir, is there any association between the pituitary tumor and the this epidural lipomatosis?
No, no association. And that's where I said there is no association.
And
See,
can pituitary tumor can give rise to this sort of rise in protein? That is, it is
yes,
different.
yeah, that's what I said. Can cause rise in protein.
Without a meningitis, without a chemical meningitis.
Yeah, without chemical meningitis. Yeah, of course. Just like even neurofibromatosis newer can produce elevated protein. Meningioma can produce elevated protein, not due to the compression, just by secreting the proteins in the cells into the cells.
What CT chest?
Pardon?
CT chest.
CT chest, all they done. I did not do it. That's done from the previous hospital. That one no. CT chest and abdomen are normal. They did everything.
We do a meningeal biopsy from the.
They did not do it. I also did not do it. But why should they do that is a question.
IgG4.
No, that's what they say. It's no whatever the investigation they have done everything. No.
The rapid trial of pituitary surgery.
What did you say?
Transsphenoidal section.
Correct. Yeah. No, that is what I did was I said stop all these medications. I said you go undergo surgery first. Take out the pituitary tumor and let us see you again. At that time, I want to see your conduction and your CSF protein is disappearing or not. Because what is causing is myelopathy is only very mild. Even if epidural lipoma is causing it, you can just wait. Ask him to get a weight reduction. And let us wait and follow up the patient. That's my way of thinking. And get a pituitary mass out, as Paramishan was telling, and find out what is happening to the patient subsequently. If the protein is causing some of his problems, that will disappear by itself. And ask the patient to get the weight reduction. That is what I want. Yeah.
So it's known that the Cushing's syndrome can give rise to epidural lipomatosis.
Yes, yes.
But, so whether he was obese, he told me that he was obese. Probably
no, obese, but not Cushingoid. His steroid, everything they are all normal. ECT, steroid, that I showed the values, no? The cortisol values, steroid, ACTH values are all normal.
Cushing syndrome cannot be caused. Cushing disease can be.
Sir, what is the histopathology report of the?
Report of?
Pituitary mass.
No, that is not operated. So I have suggested. So in fact, I sent you for surgery.
Okay, sir.
The person, this is the case which I seen last week. I have sent him for surgery to come after surgery and then reevaluate him.
Okay, sir.
So I think what the lesson is that personally I feel that, before whatever investigation abnormality you find, it should correlate clinically with the clinical findings of the patient. Some of them may be incidental, like nerve thickening in this patient, which I truly think it is incidental. Because subsequently I see another patient, just for the sake of finding whether it's normal or not, but not totally unrelated problem, you also got a brachial plexus thickening. So that these things all with these abnormalities we are picking up now, whether how far it is really abnormal, whether it's person normal population also the time will tell.
So can it also be lipid deposition or the roots?
No, but it's outside the spinal thick also.
Because there's clumping of the nerve roots, can we do a biopsy of the nerve root? One of the.
No, nobody will do that, Joy, because it's not symptom. Symptom is not there. So only if you do a biopsy, can put his deficit.
There's just one root won't cause anything, no?
But again, see, when somebody has to undergo surgery just for taking out that biopsy, cells are normal, only a elevated protein. So what is causing the protein? Two possibilities: lipomatosis or the elevated, pituitary. Tackle those things, Let us see the CS reporting coming down or not.
ACTH was checked, sir. ACTH.
Normal. That in fact, initial investigations I hadn't shown that all the investigations. So this is what I have written in my surgery. Pituitary macroadenoma, myelopathy about disease, lipomatosis, avascular necrosis, CADP, only recurring CADP recurring follow-up. So,
Sir,
yeah,
this vascular necrosis of the hip is more favorable.
it's there, but not positive. Because yes, no, I checked seeing the report, I went and do the Patrick test, that is negative, he has no pain also. That will not cause the disability. Because his weakness is there on both sides also.
I'm not the disability, but it's something related with the steroid.
Yeah, that's correct. That related to this, he has been taking for the last 6 months.
So it may go in favor of Cushing's disease, not syndrome.
But he was even obese even before in the very beginning.
The proximal weakness, is it due to a myopathy, sir, because of the steroid or something?
But the reflex are exaggerated.
It could be on the way, suppose superadded myopathy in the wake of a pyramidal lesion agreed.
Pyramidal is there.
But pyramidal lesion, myopathy, yeah, that's but you know, the weakness is so mild. That's why I'm a little confused.
Is there any progression, sir? It is very mild disease only.
Very mild. That's what I say. No, hardly any progression at all. He could get up from sitting position, even with one leg, he could get up from the squatting position, he can get up. Only thing is that with my great effort, I could break the weakness.
The CPK was normal, sir.
CPK was normal.
Is there any use? PET study any use?
PET study. They're thinking some kind of a metabolically active lesions, but there is no mass except for the pituitary tumor. There is no other growth or anything seen. And I don't think it's going to be helpful unless they think of some malignancy somewhere else, and these are due to deposits. No contrast enhancement anywhere in the rooms.
Finally, the entire picture favors more of a pituitary.
Yeah, this is what I have written in my discharge summary.
Pituitary later.
Yeah, patients got bilateral pyramidal sign. This, I think, non-committal statements with no clear evidence of element finding. The site of lesion, the pyramidal weakness located above D7. The reason for bilateral pyramidal signs is uncertain movement, which could be due to extradural lipomatosis, compression of the dorsal cord, or by strangulation of the cords will thicken towards an elevated protein. Radial abnormality thickened brachial plus cardiac and roots elevated could be experienced CADP, but there is no clinical or electrophysiological evidence to support the same. The mild prolongation FE latency below the cutoff value of the CADP is below the cutoff value of the CADP. Moreover, even though brachial plus was slightly thickened, there was no clinical finding upper lip, no EDS abnormality noticed in electrophysiological testing. So many abnormalities patients are not tallying with the clinical findings and needs follow-up. Elevated CSF protein may be due to coricory CADP or due to elevated protein secondary to the pituitary mass. The significance of mild nerve thickening in the present appendix needs follow-up. Patients certainly due to avascular necrosis. Plan to advise undergo surgery for pituitary tumor and orthopedic consultation for heme disease, and follow up after 2 months to have re-evaluation of the sections and plan treatment accordingly. So that is the discharge summary which I have written. So what do you think?
It is too much for pituitary tumor, I think.
That's absolutely right, sir. That is it, sir.
Pardon?
That is the most likely possibility, sir.
Yeah.
I think it's not pituitary.
Anyhow, pituitary is the
Yeah, everything is not due to pituitary. I agree with you. Probably the epidural lipometer is also causing the problem. But one thing, yeah,
that may also be due to pituitary.
Yeah, maybe indirectly related to pituitary, maybe. But one thing is, but
it's not due to pituitary because he's not having Cushing's. If you think it's due to pituitary, it should be due to Cushing's. But the endocrine hormonal profile is not suggestive of Cushing's.
Hormonal profile is not suggestive, but he's obese.
Cushing should be proved biochemically, not.
That's correct.
That's nature. But can this SOL cause the brainstem compression?
There is no brainstem compression. That is exactly clearly checked. That is the first thing I was looking at. Was there any compression causing weakness? No. It's only touching the coptic as.
Sir, is it possible that the pituitary tumor was active initially, that resulted in epidural lipomatosis? Later, they become null cell type. Is it possible? And inactive later on?
That is very, very, I think that is little far-fetched, I personally think so.
Then there should be an apoplexy or something like that to cause that.
Nothing. Right, in these cases, there are cases you follow. But I'm pretty, personally, I think that's unlikely to be a CAD. That's the only thing I have in mind to confirm. It was not fitting with the CAD.
So, sir, this is a pituitary tumor definitely can produce like this, sir. Because we had a just like similar small, medium-sized CP angle tumor. Is CSF xanthochromia. There was a brain full of susceptibility showing full of subarachnoid hemorrhage. Here, wondering what is happening after removing. After 3 months, everything subsided. CSF become pakka normal. All the susceptibility, all the sulcal hemorrhage completely disappeared.
Yeah, that's true. So this well-known CP angle I have seen also such tumors presenting with elevated protein abnormality. That is why I thought we'll wait and see, remove the tumor and let us follow up the patient.
So for sure that pituitary tumor also can produce the
Yeah.
It will also produce the same result.
Only time will tell me prove it. Yeah.
Recommend for surgery.
Yeah, that's what my plan is to do the same thing. And we need follow-up. After that, we'll check the CSF protein again. Weight reduction, see the lipomatosis, then decide accordingly.
Problem with the pituitary tumor causing it is like there is thickening of the plexus also. How will you explain
Yeah, that is most likely incident. That's nothing related with the it's a normal finding. Because I have seen some other patients also has been the versatile, that can be quite normal.
Can this
And Cushing's is usually confirmed by dexamethasone suppression test. The normal cortisol values and ACTS does not rule out Cushing's. You have to give midnight dose of dexamethasone and cortisol is checked the following morning. Normally there will be a suppression, but in Cushing's there will be no suppression. And fat redistribution is very much there in Cushing's. You can get this buffalo hump and things like that.
That is not there in the patient. That's not
yeah,
there.
but this epidural can still be due to that kind of fat redistribution.
Okay.
So usually the endocrinologists do the dexamethasone suppression test to confirm Cushing's.
So with normal cortisol, and with normal cortisol, you get dexamethasone suppression, or raise cortisol and you get dexamethasone suppression?
No, when you give dexamethasone in normal individuals, the morning cortisol should be suppressed.
No,
the values will be suppressed next day morning cortisol levels. But if the patient is Cushing's, there will be failure of suppression because there is excess of it.
That is if it is adrenaline origin. There is a pituitary.
No, adrenal involvement, there will be suppressed ACTH. In pituitary, there will be a normal or high ACTH.
Normal.
Your ACTH is normal.
ACTH is normal.
Yeah, ACTH is normal, but that does not rule out. No, even in ACTH can be normal.
No, but that should be in the context of Cushing's pictures. No, here is no hypertension.
Yeah, of course, there is nothing. But I was just mentioning that just biochemically, just normal values does not rule out. That's what I was saying.
Yes.
Right.
That's right. Definitely.
That is right. Agreed.
Okay. So,
Sir, one doubt.
Yeah.
Sir, that initially that patient had that burning sensation, no, of the legs.
Yeah.
So how will we attribute that, like, to the posterior column sensation in the dorsal spine?
No dorsal column. Maybe due to the spinothalamic tract involvement. There is some compression of the cord somewhere. Yeah, from the periphery.
But examination, we did not get anything, no, sir?
No, examination is only finding a decreased temperature sensation below knee. And moreover, an objective sensory loss need not be there because, as you know, the sensory symptoms precede the signs. So you can have sensory symptom without any objective evidence of sensory loss. Still, that tract may be affected. Classical example is thalamic infarct. May come with varices and numbness. You don't find anything on examination.
Yes, sir.
Okay.
So avascular necrosis of the femoral neck.
Yeah.
There should be some steroid abnormality.
No, he was already, he has received steroids. No, that's the reason there is a.
This has received for 6 months.
Okay, agreed.
Sir, this lipomatosis, the epidural lipomatosis, will it cause compression and myelopathy?
Yes, it can. It can. If it is a large, it definitely can produce compression. No doubt about it.
Without any signal change, without any signal change in the code.
That's a little odd, but even this is not like an acute compression. This is slow compression occurring in the cord. So that case sometimes may not produce signal change.
So he was on prolonged steroid treatment.
Yeah, but this lipomatosis was there now or previously we do not, because nobody has investigated that today. This is like only now. Okay.
Sir, what is the previous MRI? Was there any lipomatosis in the previous MRI?
No, previously nobody did a thoracic MRI. All did only cervical MRI. The one which I showed you the first MRI, no?
Yeah.
Sir, previously that MRI was showing contrast enhancement, lumbosacral region. Never.
No, the thing is that the first claim I showed was done when they subsequently he was admitted in the hospital. There the MRI picture is not with me. Only the result is there. That result I have shown. What they have written. There they have written nerve thickening, mild enhancement, everything is written.
Okay, mild enhancement, that report only is there.
The output only is there.
Okay, sir.
I think I don't have time for a next is a long case. I think I'll skip that. I'll go for a short. Yeah.
Surgery discuss.
Surgery we'll discuss that thing.
So
what short case I should show you?
Sir, one doubt, sir.
Yeah. Yeah, please.
Sir, suppose in these kind of situations, he has already been put on steroids.
Yeah.
So suppose if it is an enhancing lesion, will
disappear.
that reduce with the steroids? Just like, your cell count gets decreased in meningitis. Does this enhancement become a non-enhancing after about 6 months of steroids?
No, on 2 points again is even the first CSF which had they done earlier, there was no cells, only elevated protein, and there was only plenty of RBCs. Second thing is that even though you said that enhancement is disappeared and not, he had no clinical improvement. Whatever symptom he had, he come with the same symptom. That is why he came to me. So apparently that improvement, I don't think it is much is there in this patient. It's only presumption that by contrast might have been improved like that.
Okay.
Okay. Anything else for a short case also, you'll stop.
Short case. Short case.
Short case. Okay, I'll show you the short case. This is a 23-year-old male. He noticed difficulty in elevating his right foot incidentally when he went for a driving test 6 months back. He also noticed loosening of the chappals and mild dragging on the right foot while walking for the last 6 months. This is not that short case, it's long. No sensory complaint, no root pain, no complaints pertaining to the upper limbs. So in fact, he noticed difficulty in elevating the right foot, loosening of the chappals for 6 months. This is the examination. His spineless broad normal. Upper limbs normal tone, normal power.
Excellent.
Over is normal.
ഇങ്ങനെ പിടി, ഇതും പിടിച്ചേ, ഇങ്ങനെ കാണിച്ചേ, എൻ്റെ വിരലി തൊട്ട് മൂക്കി തൊട്ട്
No incoordination.
വിരലി തൊട്ട് മറ്റേ വേണ്ടി ഇത് ശരി മൂക്കിടക്ക് സ്റ്റിങ് വന്നേ.
So I found that he has mild wasting on the right leg and mild shortening on the right leg. And the right foot is shortened and it is the talipus equinovarus. He's got contracture of the tendo Achilles and inverters of the right foot. That's a position for the right foot.
ചുമ്മാ ഇട്ടാ മതി,
Tone is a bit rigid on both lower leg.
ചുമ്മാ ഇട്ടാ മതി.
Both sides he was holding it or not, other I am not sure.
മതി വിട്ടോ, ഇത് പൊക്കിക്കേ.
Flexion was normal.
ഈ മുട്ട് മടക്ക്,
Extension normal.
ചവിട്ടി മാറ്റന്നെ, അത് തന്നെ ചവിട്ടി മാറ്റും മാറ്റും, അത് തന്നെ ഇത് ചവിട്ടി മാറ്റും മതി. ഈ പാദം ഉള്ളോട്ട്
Dorsiflexion normal on the left side.
ഇത് പൊക്കി പിടിച്ച് മണി, ഇനി പിടിച്ചോ.
He has got mild weakness in the dorsiflexion inverters.
കണ്ടവരിൽ പൊക്കിക്കേ,
Nature is also weak.
പൊക്കി പിടിക്ക്, ഇത് പിടിച്ചേ, പൊക്കി പിടിച്ചോ,
That is
ഇതും
normal.
പിടിച്ചേ. ഓക്കെ, ഇങ്ങനെ ഇങ്ങനെ ഇരിക്കണം,
Inverters was good power.
വെളിയിലോട്ടൊക്കെ സമ്മതിക്കില്ല. അങ്ങനെ പിടിച്ചോ, ഇത് അകത്തോട്ട് പിടിച്ചേ മതി. ഇനി വെളിയിലോട്ട്
Inverters were weak.
പിടിച്ചോണ്ടിരിക്കണം, വിടില്ലേ, ഇതും പിടിച്ചോണ്ടിരുന്നേ മതി. എൻ്റെ കൈ ചവിട്ട്,
Plantar flexion normal.
ചവിട്ട്, ആഞ്ഞ് ചവിട്ട്. ഈ തള്ളവരിൽ ഒന്നുകൂടെ പൊക്കി പിടിച്ചേ മുകളിലോട്ട്, ഇത് പിടിച്ചേ കീഴോട്ട് മടക്ക്.
Flexor pollicis longus is also weak on the right side.
ഈ മടക്കി ഇങ്ങനെ പിടി, പറ്റണില്ല അല്ലേ. ഇത് മടക്കി പിടിച്ച മോനെ, ഈ മടക്കുന്നത് പോലെ ഇത് മടക്ക്, ഇത് പറ്റണില്ല. ഇത് ഇറുക്കി പിടിച്ച് എൻ്റെ വേറെ ചേർത്തെങ്ങ് പിടി, മുറുക്കി അങ്ങ് പിടി, എൻ്റെ മുറുക്കി അങ്ങ് പിടിച്ചോ, വിടരുത്, അത് തന്നെ വിട്ടോ. ഇത് മുറുക്കി പിടിച്ചേ,
Adductor is also weak.
കാലകത്തി പിടിക്കണേ, അടുപ്പിക്കാൻ സമയം.
Flexion was normal.
അത് വിട്ടേ,
Adduction was normal.
മോനെ അങ്ങോട്ട് ചെരിഞ്ഞ് കിടന്നേ മതി, നേരെ കിടന്നു.
There is normal hip abduction. Reflex in the upper limbs were normally initiated.
ഇനി കൊടുക്കില്ലേ. വേണ്ട.
Reflection also normally initiated. Abdomen reflex intact. Lower limb
കൊടുക്കണ്ട, പനി കൊടുക്കണ്ട, അങ്ങനെ ഇരിക്കട്ടെ.
region, this bilateral.
പനി കൊടുക്കില്ലേ, പനി കൊടുക്കില്ല.
Angle jack was normal. Normally initiated. Plantar was indefinite, but either not going or ungoing. Sensations were all normal.
ഇതൊക്കെ ഒരേപോലെ അറിയാമല്ലോ, വ്യത്യാസമില്ലല്ലോ. ഈരിപ്പ്
Sensations were all
അറിയാം,
normal.
ഇതും അറിയാം. ശരി, ഇപ്പോഴേ 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 ഇപ്പോഴേ
Normal. So this is the gait of the patient. He walks with a foot drop on the right side. He cannot stand on heel, but he could stand on toes. Could stand on toes, but cannot stand on heel. And his right foot goes into inversion while walking. It's already inverted. So right leg is wasted compared to the left. Right thigh can be shortened. Canelus normal, motor upper limbs normal. Lower limb, both lower limbs are quite rigid on trying to lift his both the lower limbs. But walking, I could not see that thing. Talipus equinovarus deformity due to contracture of plantar flexus inverters. Weakness of dorsiflex right angle, right EHL, flexor hallucis longus, mild weakness of the inverters and adductor hallucis. TTR, knee jack is bilaterally, ankle jack normal, plantar indefinite. Cell system normal. Good drop.
Duration is 6 months only.
Like in fact, he noticed this is a story. Driving test, he went for a driving test. He found that he cannot put his foot properly on the accelerator or brake.
Yes, whatever has happened long back, sir, because of the skeletal deformities.
Okay, very good. So what do you think?
Childhood onset might be bilateral breast reflexes, deformities, could be pyramidal, old infantile hemiplegia, or
It is bilateral.
Left parietal wasting could be congenital, some porencephalic or that particular area.
But he has no spasticity. It's only foot drop.
With tethered cords.
Need not be.
Yeah.
Sir, has he got hypertrophy of the calves with the contractures, hypertrophy?
Yeah. Atrophy of this thing and contraction calf, yes.
Is it possible to have a myopathy, something like a long-standing myopathy?
My only one limb, brisk reflexes in Egypt.
No, brisk.
Tethered cords.
Tethered is.
But there's no element findings here.
It should be a cerebral,
no?
Cerebral cause.
Cerebral palsy.
Okay, so what Ruba and Soumya was telling. So, so what do you want? Conduction was normal. What do you want?
MRI brain.
Exactly. Which part? Brain. This is
Yes.
Yes, you find that thing, no? See this atrophy of the left part of the parietal lobule, atrophy here. This also slightly atrophied, but main trend is the left parietal lobule. It is this side one. Here. Now, what is the clue? He says, Siruba, or I don't know. Shortening of the limb on the right side. That tells you the lesion has been there from early life. That's the clue. So, in fact, that's a clue to make you suspect that this is cerebral disease. And as she was telling, that spasticity may not develop in cortical lesions confined to the pyramidal location alone. Because spasticity is maintained by the cortically or the extrapyramidal fibers, the area, forest, etc. Confined only to the motor strip in that area, you won't get spasticity. So that's a finding. So it's only a short case. Can somebody's mimic an element palsy, but always look for the shortening. Long-standing weakness also can get contraction.
And it was unnoticed till then. So that is also.
That's another point. Because he has been having it for long. They thought it is quite normal for him. Okay. People think, oh, from birth onward, this is walking like that. It's normal. So when he went for this thing only, they noted this problem. Okay, it's something like infantile coronal monoparesis. Infantile hemiplegia like thing. Okay. Any questions? Okay.
Nice case, sir.
Okay.
Dynamic CP, syndromically CP, can we say CP?
Yeah, it can call a CP, agreed. Yes, it can be cerebral palsy. Or one limb. Okay. Shall we stop?
Thank you, sir.
Okay, thank you. Good night.
Thank you, sir.
Thank you, sir. Thank you, sir. Good night, sir.
Thank you, sir. Thank you, sir.
Next week I'll bring another good case which I had with me now, but because of the time I am not present.
Good night.
Okay.
Good night, sir.
Okay, sir. Good night, sir.
Thank you, sir. Good night, sir.
Good night, sir. Thank you.
Thank you. Good night, Feroz. Thank you.
Good night, sir.
Good night.